Okay. Yeah.
Mm-hmm.
I thought there was another one coming. No.
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 Something bonged.
Yes, I just started the recording.
Ah, okay.
And last time we did it, we actually had everything recorded except for the audio. I had misconfigured my PC. Actually, we changed from Skype to Google Meet, and Skype wouldn't let go of the audio channel.
Oh dear.
So this time,
Ain't technology wonderful.
yeah. So this time, I'm being careful. I even have my cell phone recording the conversation as backup.
So what time is it in Newcastle now?
It's almost 4 p.m.
4 p.m. Ah, yes.
Yes. So this
And
is
you?
quite a civilized time compared to
Yes.
some of the webinars.
By you, Ken, it is 11 o'clock, is it?
It's 11 o'clock at night, yes. Well past my usual bedtime. But for you, for a beautiful young woman, I'll gladly stay up later.
No, it's a pleasure to do little conferences like that because it makes you think. I mean, I've done probably 200 in my life, and each time I find a new idea when I do this. I find new links that I don't know why I didn't see before. For example, the principle of cyst, biofilm, and Morgellons, it's new to me. Well, I always had it in the back of my mind, but this time I can clearly say it. And also, because I see a lot of patients, when I figure it out, I see it's a bit different, but not really different. Catherine Alwood. This is...
Yep. Give her a second to get her system going, I'm sure. She's muted at the moment.
Yeah. But it's very interesting. I used to do twice a year at UNESCO with Luc Montagnier, but now he died. So UNESCO is not active anymore. Everyone of the Cronimet group has kind of disappeared. So there's another group in France, Le Grain, that will start June next year. I'm invited to give 2 conferences there. And then I was always also part of the ILATS. Hello, Catherine.
Hi, Dr. Jadin.
Sue Wolf, Nick Mel. Oh, we are quite a few people now.
Mm-hmm. Yeah, Sue is also in Australia.
Oh, yes. Where in Australia, Sue?
Give her a second. She's
No,
probably...
no. Fixing something.
Mm-hmm.
Nick Mel.
Hi everyone. Hi.
Hi. Good morning, evening, or whatever time of day it is for you, Nick.
It's 7 a.m. UK.
Okay.
Is everyone there ready to start? Or Nick Mel is still... Ah, and Tess. Tess, I know you. Hello, Tess.
Hello.
Hello.
For those of you who are not familiar, Tess is part of the microbiome remission project for using antibiotics to treat chronic fatigue syndrome. Okay.
So, shall I start?
Yes, please do. If somebody comes in later, there will be recordings available, including hopefully with subtitles.
Okay. Well, I'm very happy, and thank you, Ken, to let me think together about rickettsiosis and other obligated intracellular organisms. So when you have when you have a tick-borne disease, I don't say a tick bite fever, a tick-bone disease, you are exposed to all the specialists. Those germs can come into your lungs, your intestine, give you heart problems, motor neuron diseases, or any neurological diseases, psychiatric diseases, nephrology, dermatitis, sinusitis, rheumatoid arthritis, or anything like this. Ophthalmic, you can also have genetic deformation, muscle atrophy, prostatitis, gynec disease, and pancreatitis. Next, I'll tell you why. Do not take the end product, meaning the symptoms, as a disease. There's only one way to do medicine. Find the cause of the pathology, not where the problem is situated today, because it will move tomorrow. Next. A medical diagnosis is generally issued from the patient's symptoms. So you put the symptoms together and you make from this a disease. And you call it fibromyalgia, chronic fatigue syndrome, ME, yappy flu, lupus, rheumatoid arthritis, AS, myasthenia, which is very much of a fashion now, IBS, autism, etc. They are generally a secondary condition of a complex primary infection. Modern medicine treats them according to an appropriated medical dictionary, not worrying about the possible origin. That medical dictionary will never solve the condition because the cause is not looked for, and furthermore allows the attackers to move into the human body under different names, according to their location. Next. Because a germ does not give its name to the disease, but the name of its position in the body. So Mycoplasma can give you anything. Bilasia can give you anything. It depends where it is situated in the body. And there is no borders. It moves from one side to the other, according to its nature, to its activity, to its laziness, to it going dormant, to active. Next. Example. This is a true story. I had a patient about 30 years ago that entered medicine with an acute appendicitis, which is often the case because, as we all know, the appendix function in the body is to swallow the toxins emitted by germs in your body. So the appendix is overworked and gets infected and very often needs to be removed. That patient, after the appendicectomy, developed a myelofibrosis. She refuses to take the treatment of chemotherapy and came to me. I found some germs, I treat them. It took me 2 years to reverse the myelofibrosis. Then she had a heart attack that was treated with stent, followed by a rheumatoid arthritis, treated with antibiotic, but always the treatment was a bit too short because she really didn't like to take medicine. The rheumatoid arthritis became unclearly a lupus. Then she developed a colon cancer, redirected to the psychiatrist for depression. She had a few epileptic attacks, treated with antibiotic, and now, recently, she developed a glaucoma. This is very common to me. Glaucoma are very much part of rickettsial infection. Chlamydia is the biggest cause of blindness in Africa. So don't we find that there is a need of stitching or connecting this not so rare case? We must connect it. There is a reason behind this. It's not by accident that the same patient developed all those conditions. Next one. The reservoir of the germs that we are talking today are found in rats or in other rodents, in bats, in uncooked animal products, so unpasteurized milk, unpasteurized cheese, uncooked meat, and also in any reptile, gecko, crocodile, and so on. Next. The vectors that they have to distribute their germs are tick, flea, lice. Next. You don't need to be bitten because the droppings of the rats and the rodents and the bats are containing those germs and will with time become dust. So the dust will touch any patient, going through the skin, the eyes, the nose, the throat. Next. Lyme is actually not a disease. Lyme is a village in Connecticut. Lyme disease is a dangerous appellation, blinding the presence of other obligated intracellular organisms, leading, I've seen it often, to seronegative Lyme disease. This doesn't look scientific to me. Rather use the term borreliosis for this bacteria, found by Amédée Borel in the 1920s, I think. Next. Brief historic about borreliosis. In 1702, Drury found the borreliosis in Central Africa. In the 1900s, it was sent in Spain. In 1920, Charles Cole was working in Tunisia and came across the same borreliosis. In 1933, in Congo, Schelt did the same discovery. In 1944, in Cape Town, it was the turn of Palakov to identify the borreliosis. In 1950, in Kenya, Ace did the same journey. Helen Sparrow, she was a student of Charles Nicoll, found it in Ethiopia in 1950. And then came Burgdorfer in Connecticut. It was a village of the village Lyme. There was an epidemic of rheumatoid arthritis in a school in 1975. There was born the name Lyme disease. Forgetting about borreliosis, which is actually a very sad mistake. Next. Also to insist that that germ is not a new germ, the Otzi mummy found in the Alps in 1991 was full of arteriosclerosis with DNA Borrelia burgdorferi in her brain, and she was over 5,300 years old. Next. In our practice, we look systematically for all those germs. So if I show you, coming from the up left, this is written in small Coxiella burneti. Coxiella and Burnett found this germ in 1920 about. This is Q fever, called Q because query, that fever that was coming all the time was called query fever. Coxiella and Burnett found that germ, had a Nobel Prize for it, and then, as there was no antibiotic those days, treat themselves with methylene blue, and both die of it. Left of this, you find a worm. Worms are also distributed by ticks, fleas, and are in the air. Under this, we find the Rickettsia connery, found by Dr. Connor. Above this, the yellow little thing is a Chlamydia pneumoniae. Above this again, we've got the mycoplasma, where you find a red cell floating in the middle of green little bodies that are mycoplasma. Under this, we find the face nearly human of Giardia. Under that, the horrible little Helicobacter pylori that can come from the stomach into the brain. About all my patients having MS, Parkinson, motor neuron disease, present with Helicobacter pylori. Now, if we stay down there, we find the toxoplasmosis. Toxoplasmosis, this is the Toxoplasmosis gondii, that goes into cysts. Those cysts are not really dangerous if they don't burst. When people fall, like after ski and things like that, Toxoplasmosis gondii go all over, and it's a great big problem. Above this, we've got that little blue and yellow body, that's brucellosis. Brucellosis is well known as a disease, a farmer disease, people in contact with meat. But the hunters are also in contact with meat, and any people that cook raw meat will touch it. So the brucellosis in those days is very common. It affects a lot the joints, give big joints pain and diseases. Above this, we've got the Lyme, the borreliosis. On the right of the borreliosis, we have the Bartonella and Cele, also called cat's scratch disease. Next to it, we have those red blood cell with a green little thing called Bartonella quintana. Bartonella quintana was the germ that killed Napoleon army more than the bullets. Just a bit towards down this one, we've got a big worm, Bilasia, very dangerous germ. Below that, we've got the Chlamydia trachomatis, that is thought to be a sexually transmitted disease, but in my patients, there's a lot of young people, 6 to 12 years old, that are positive for this and mother negative. So I doubt about this origin. Okay, next. Our observation, that's also very disturbing for a lot of people, is that we have 2 antibodies that are protecting us from germs. The IgM is a big molecule. Its size is big. It can go into the tissue. So it stays into the circulation. People think normally that IgM is a new infection. No, it's not a new infection. Each one is following the trajectory of the pathogen, as we regularly see in our patient serology. They will produce alternatively IgG and IgM. IgG, as you see on that slide, is a very small, tiny molecule that can enter the endothelial cell and also the tissue. So it's not an old infection. It means that the germs is moving. Very often, when you find IgG to start the first visit and 6 months later of antibiotic, the same germs go into IgM. So it's not like, established like this IgM new, IgG old. No. In my practice on thousands and thousands of patients, I say it's not the case. Another very important thing is a germ never presents alone. That's why if you look for borreliosis, you're wrong, because borreliosis is never alone. Next. We evaluated to single out the carriers from the sequence. We, of course, consider the symptoms of the patient, but we look for the full blood count and the ESR that shows the activity of the germs. We also investigate the iron study, which we'll find often a saturation of iron low and a ferritin high. The liver of a function, because those germs are very toxic for liver. Kidney too. The cholesterol, which is about omnipresent with mycoplasma. Cholesterol is needed for the germs to grow. The sugar varies according to the activity of the germ. The thyroid is well appreciated by those germs because it is rich in iodine. The CRP, the rheumatic factor, the antinuclear factor, the creatinine kinase, and the cardiolipin are an autoimmune response from the body to the attackers. It is not a condition. It is not a disease as such, as by treating the germs, those factors disappear. So it's not a condition, autoimmune disease. It's an autoimmune response. The protein electrophoresis measure the condition of your immune system. Does it work too high, too low, or is it normal? The IgE is allergens that people produce against the germs. It becomes, after a while, aspecific, and it's against food, against dust, against cats and dogs, and very often doctors only look at food, cats and dogs and things like that, and don't realize that there is a switch that's put on because of the germs. Next. Oh, this is the wrong version. But it doesn't matter. I have another I correct that version, but it doesn't matter. I will explain to you that now. Here, seen at front of the Pasteur Institute of Tunis, there are two stills erected in 1936, as my father, Professor Cecile Jadin, was working there. I went there a few years ago, and I was wondering why, at front of the Pasteur Institute, there are the same germs that I deal with. I asked Professor Ali Boitou, that was working there those years, why are you still doing that? He said, of course, what else are you doing in medicine? So are we dealing with a unit of pioneer in medicine? Why is it only in Tunisia? You don't find it anywhere else in the world. So there I say typhus, the neglected killer. The typhus was also found in, I didn't put it there, but in the Middle Age, when Thucydides was having his war, Socrates, there is a very good book called Madame Socrates by Gérald Massadie. If you can read it, it's very interesting, saying that Socrates lost Athens and the Peloponnesian War in Macedonia too because of fleas. They were infested by fleas. Same thing in the Crimean War, the typhus killed people. We see there a statue that was erected after the massive Irish migration in Canada in the 1847. The Irish people were having typhus and were in quarantine before they could come into Canada for years. Next, please. In the Nazi concentration camp, the typhus was all over too. In Ukraine, in those days, all the doxycycline of France, Belgium, West Europe are gone to Ukraine. It's the wrong way to treat typhus, but it's the normal way they take doxycycline. The migrants via Mediterranean Sea, they're also full of typhus and bring it where they go to. Tarasevich, a Russian writer, claimed that 3 million of people died of the same typhus during the First World War, just to name a few. Next, please. Typhus means stupor in Greek. Stupor was the name used by Homer. Homer was a Greek philosopher before Christ that was saying that when the big white birds were coming from Africa in Athens, the whole population was plunged in a state of stupor. Typhus is rickettsia. There's more than a few hundred species. Q fever is included. And now we speak about the neo-rickettsia, which is Mycoplasma and Chlamydia. Next.
Okay, may I just pop in? The word stupor, the modern equivalent is probably the word brain fog.
Exactly. I should have said that. It's brain fog.
Okay.
Yeah.
Yeah.
Yeah. Just like brucellosis, toxoplasmosis, Helicobacter pylori, borreliosis, babesiosis, Bartonella, they are obligated intracellular organisms. Therefore, they will require a specific treatment adapted to their multiplication rhythm, which is a month, and their intracellular position. The treatment that we use consists in 7 days per month of antibiotic, as it takes the OIO 4 weeks to fill in an endothelial cell when they are active, because they are rather lazy germ and they're not active all the time. So we take 2 antibiotics, a bacteriostatic to open the cell, combined with a bactericidal to kill what is inside. If you use the bacteriostatic by itself, it's like putting a red carpet for the germ. They can just walk in the blood vessel and find other endothelial cells to invade. If you use only a bactericidal, you will kill the germs that are looking for another cell. After killing the mitochondria of their cell, they need some more food and they go somewhere else. We alternate our combination to avoid mutation, to avoid destroying normal cell, and to allow normal intestinal bacteria to be restored between the things. Between the treatment, sorry. In considering the modern alimentation, antibiotics given in meat and fish to the animals, the daily intake of probiotic is recommended. We don't have, with using our pulse therapy, we don't come across a lot of guts problem. The daily intake, so we recommend the daily intake of probiotic. The treatment also includes vitamin B complex, as the antibiotic refrain their normal production. Is there a hand that wants to ask a question? No. No, the hand has disappeared. The treatment, we also give proton pump inhibitor to protect the stomach from the antibiotic aggression.
I'll just quickly inject here. I checked my database for proton pump inhibitor, and it actually is interesting because it encourages the growth of both bifidobacteria and lactobacillus. So it's almost a prebiotic by itself, which was found interesting when I looked it up. I was curious, and it encourages almost all what are commonly called used probiotics.
Yes, I agree. Yes, our choice of association of antibiotic for adults. I don't think I will read that. You have it printed somewhere. We always to say something about the ciprofloxacin that have in our days a very bad name of fragilizing the tendon, even tearing them. I haven't seen that through all my practice, but I always recommend it when you take it not to do exercise. Of course, we consider the allergy of certain patients to this and that. The Dapson is now very fashionable in America. due to Horowitz, but it's actually a product that was invented by my father for the leprosy. It can be give you blue lips. This is a genetic fact due to the hemoglobin being changed into methemoglobin. All those antibiotics has to be taken after food, not only water, as you see often on the internet. And also, very important, without any dairy products that will diminish their absorption. Patients must avoid sugar because sugar feeds the germs. Sugar, magnesium, and glutamate are feeding the germs. I was feeding the animal in my father's lab, meaning guinea pig, rats, and chimpanzee, with sugar, magnesium, and glutamate to make the rickettsia and neorickettsia grow better. A thing that I would like to insist on is the vitamin D. The vitamin D is, as you can see there, the main product to kill rats. When you give EcoRat to rats, there is the stone that comes out. We are big rats, so it's not going to happen overnight, like for them, but it's going to happen. I've seen lots of patients with big damage on fingers that had to be amputated and things like that after taking a lot of vitamin D. I had yesterday a new patient that had already 5 operations to remove calcium plaques in the shoulder that she can't move anymore after the intake of vitamin D. Especially during the COVID, everyone said, take vitamin D, which the consequences are coming now. Next, please. Patients are also given Nidaquin between antibiotherapy, not with, in case of the presence of autoimmune factors. See the copycat mechanism of the OIO. They cover themselves with the host protein as a protection against antibodies. So when your immune system comes there, it can't see it. If you take Nidaquin, it peels those proteins off. It's well described in the copycat mechanism. Careful, side effects of Nidaquin is possible, but very rare. It can give you black spot in your eyesight. This is reversible, but you stop if it happens. Patients are also given Silimarin, in other words, Legalon, in case of liver toxicity. Biltricid, if needed, has to be taken a week after the antibiotic. Deworming every 6 months. No vaccine except the children's requirement, of course. No deep massage, that's especially for toxoplasmosis, and for any other one that makes cysts, because the cyst will just burst. Do not remove your teeth filling because it makes always the situation worse. Treatment controls the multiplication of the germs rather to get rid of it because relapses do exist and are frequent. But they can be controlled again and easier than the first condition. Next, please. Bilasia. Bilasia, I think it's very important to speak about this. People say that Bilasia is a South African or African disease. Not true. People, as you see, migrate everywhere with their germs. It's a worm that measures 5 centimeters, as big as a matchbox. Very often people that have it complain about a feeling in the thighs, feeling of things moving in the thighs. Next one. It's omnipresent on Earth. My friend, Professor Tim Roberts, always tell me there is no Bilasia in Australia. But I see him often coming to Botswana to recruit some students for his Newcastle University. He recruits a student, but they're full of bilharzioses. And it just means 1 or 2 peeing there, a snail passing by, taking the egg, putting it in form of circadia and then miracercadia that someone can touch, and it's in your system. Bilasia is a very lazy worm. It lays, when it's active, 200 to 2,000 eggs a day. Its lifespan is 40 years. It rarely causes hematuria, but more often epilepsy. I was the doctor of a competition dam in the KwaZulu-Natal and had so many young people with epilepsy treated with biltricid and recovered. The Bilasia kills more than 300 people per year. Per year. 300 doses, yeah. Eggs will be retained in a pocket of calcium, mimicking a tumor or a cancer. I had a few patients treated for cancer, and when we had the possibility to remove that tumor, it was like that picture on the bottom there, a pocket of eggs in a pocket of calcium full of eggs. I had a friend like that. This is a photo of a friend of mine living in Cape Town that had an entry for cancer, and eventually we took the tumor out that was in his lungs, and that tumor was full of eggs. The treatment, so it gets through the blood-brain barrier. The treatment needs at least 5 years of therapy, praziquantel, twice a year, according to the weight of the patient. Yeah, next please. So I always say that, wash the body, wash the organs, do not remove, do not transplant. My antibiotic are the washing powder, and the patient's body is the washing machine. Next. There is a link between obligated intracellular organism, virus, fungal and cancer. Obligated intracellular organism open the way to virus entry, leaving fragilized tissue. The same for fungal infection. Virus and fungi are treated in between antibiotherapy if required. Being intracellular, OIO will modify the cell morphology, exercising a pressure and changing the morphology. The modified cell will be cloned as well as the original cell. Here is the birth of a cancer. Next, please. Link with cystic forms, biofilm, and Morgellon disease. This is, where did I put that? My book.
Okay, I'll just.
Here. This is a different appellation for different manifestation of the same pathology. It's amazing because when I've got recently a lot of Morgellon disease, I treat them the same way, and the little cysts that they have under the skin, pretending it's material or textile, things like that, disappear. So I think it's the same reality with a different appellation. By the way, in cancer, often we find fungi and virus are present. Next one. So that story has no end. I wish it would start again with seminar given regularly for those who are interested. We need to rewrite a new syllabus of medicine to see it more clearly, not just to refer to what we know, because it's a living world. It's not something static. Anyone has any questions?
I'll make a couple of quick comments. Chronic fatigue syndrome has a increased incidence for cancers after it. So it is comorbidity there. The thing is, once you get into one thing modifying something else, things just becomes complicated or messy depending on your point of view. And the thing is, OIO also infects the bacteria in your microbiome. So there is all sorts of interesting connection all over the place if you can keep your thinking wide enough, rather than trying to focus on, oh, it's just, oh, I have HHV6, that's the cause of everything. Get rid of the HHV6 and I'll be in remission. Which, strange, we have not to see that demonstrated anywhere. People keep hoping for that, but it doesn't work. Just for those of you who don't know me, I did Cecile's protocol 25 years ago, and it worked. And then a few years later, I had a relapse, repeated again, and it also worked. So it does work. And what I find myself particularly interested in, and one of the reasons I try putting this together, is that the thing is, the protocol actually probably comes from 50 years of clinical experience, because she's been doing it, and then she brought it from work her father was familiar with at the Pasteur Institute of Tropical Medicine. So the result is you have just horrendously long clinical experience of treating a style of conditions, which I'd rather not reinvent the wheel, because reinventing the wheel means lots of failures usually. Okay, I'll shut up and somebody else please speak.
I'd like to ask something. I'm trying to think of how to combine what Dr. Jadin is saying with what you give us on your site, the suitability of antibiotics depending on the microbiome. And I'm wondering if we can follow that and combine it with Dr. Jadin. What do you think?
Okay, what I have stated and often found is that when I do my microbiome analysis, the top, within the top 5 or 6 antibiotics recommended are the same ones that she uses.
Okay.
And which sort of, it was interesting, just keep showing up the same ones, and there's a feedback use. The OIOs will send false signals to the microbiome to produce chemicals, which will alter the microbiome to feed these organisms. And my goal is to disrupt the feedback. If you normalize the microbiome, then the OIO is not going to be well fed, and hopefully will be sufficiently diminished by being starved out.
Yeah, I agree with that.
Yeah. One of the reasons I ended up getting into it came from Australia, Australian study from 1999, which I never really paid attention to till later, which mentioned the bacteria shift seen in chronic fatigue syndrome. And when I looked at it again, I looked at Dr. Jadin's protocol and cross-reference and said, guess what? These antibiotics are the right combination to correct the overgrowth and the undergrowth. It just was a matchup for me, in which case then the light went on. Okay, if people can't get antibiotics, there are other ways of altering the microbiome. Probably the fastest way is with antibiotics, but it's not the only way of doing it. That way, unfortunately, gets pretty complicated pretty fast, but it has the joys of not necessarily requiring a physician to give you a prescription. But my first preference is following, or at least some resemblance of Dr. Jadin's protocol, because it has so many decades of clinical experience with it. So
Thank you.
you're welcome. David, are you still awake? Do you have
Looks
any
like.
questions?
I'll turn on my microphone. Yes, I'm still awake. It's just a bit cold here. Yes, how do you test for these things? Are there tests that can be done to determine if you have borreliosis or any of these things? Are they testable?
Yes, of course.
Yes, of course.
You just have to have the right lab.
You just have to have the right lab.
And that,
Yes,
that's where
that
it's
doesn't
complicated.
exist in Australia.
And that,
It's a
that's where it's
serology in
it's a
serology.
in serology.
Mm.
But you must have the right lab, and that's where
But you
lots
must
of
have
folk are
the right
coming
lab, and
in
that's
there
where,
that know
lots
nothing
of
about it
folk
and just
there
invent a test, and money is a problem in that.
money is the problem in that.
Because it's so
Mm.
difficult, it's so long and so unknown
so
that
difficult and so long
new
and so
people that have
unknown that
no
new people that
experience
have no
just improvise a test
experience
that's no valid.
that's no valid.
Yes,
That's a big problem.
That's a big problem.
we
But
have the
here,
problem in Australia where
But
the
here,
authorities deny that borreliosis exists in Australia, so therefore no tests are available. And when you say, well, how do you know? Because there's no tests, it just goes around in a...
there's no test for Bilasia, there's no test for so
there's
many
no
for
test for
rickettsia.
Bilasia, there's
When
no
I
test for
was,
food.
last time I was in Australia,
When I
I
was
did a
last time I
conference
was
in
in
Manly,
Australia,
in
I did
Newcastle,
a conference
and in
in Manly,
Melbourne. And
Newcastle,
in Melbourne,
and
there
in
was
Melbourne.
a
Mm.
B Long
In
hospital.
Melbourne, there
Do
was
you know that
a
one?
B-Long hospital. Do you know that one?
No.
No. Well, Tim
No.
Roberts
No.
opened it for
Well,
me, and they were going to do
Open
rickettsia
it for
there,
me, and
but it
they were going
never
to do rickettsia there. But
finished. Huh?
It never
No,
finished.
because
Huh?
I bought some rickettsia from
Mm.
the B Long
Because
hospital.
I
And
bought some
right.
rickettsia from the B-Long hospital and right.
So when I came in South Africa, there
When
was
I
no
came
test
in
for
South
it.
Africa,
And
there was no
I spoke
test
to
for
my
it.
dad and to say, well,
And,
yes, I
I
can
spoke to
do
my
that,
dad
but
and
there
he
is no
said,
test for it. And
yes,
he
I
said,
can do that,
just
but
ask
there is
one
no
of
test
the
for it. And he
big
said,
lab in
just ask one of the
Johannesburg to come and
big
see
labs
me, and we'll
Johannesburg
organize
to
for the
come see me,
reagent.
and
And
we'll organize for the reactions.
Dr. Louis
And
Van Droen and two colleagues went
Dr.
to see
Louis
my
Van
father,
Droen,
and my
went to
father
see my father,
set up
and
a lab
my
for
father
them
set
in South
up
Africa.
a lab
And it works. It works
in South
absolutely.
Africa.
And we had those big discussion with Luc Montagnier, the Nobel Prize of Medicine for AIDS, when he was alive. He wanted to develop a test for those germs with the memory of the water. I don't know if you heard about that, but he did that for 30 years and he never achieved it. So I'm sure that the water has some memory, but practically, how do we do that? He said that he didn't trust the serology, and I would understand because serology could be scar tissue showing antibodies. But that's why we need the symptoms and we need all the dysfunction tests to see if those germs are active now or were active only in the past. Well, if a person present with symptoms, he has a problem. So you go and look in the liver, in the kidney, in the white cells, everywhere, and you will have information. If you've got autoimmune factors, it's a fact, there is a problem. Who made those autoimmune factor work? Something behind this. So if we put those three entities together, the serology, the dysfunction, and the patient, we have an answer. Does it make sense?
David, I muted you. Unmute yourself because of the feedback echo.
Oh. It seems so obvious, but not recognized by conventional medicine generally,
That's why
which is
we
a
need
challenge with
to
all
do
of
a
these
new
things.
syllabus.
You need to know.
A new syllabus. Because those things are not in the air. They've
Because those
been
things are not
there
in the
for,
air.
as you
They've
show,
been
as I show you,
there
for
for
centuries. Even Homer knew that. And now in modern medicine, it's not obvious. That's what is so shocking for me. And people are coming to see me from the whole world. I've got Australians, I've got Americans, I've got Canadians, I've got Europeans, they're all Chinese, they all come here. I had a practice in Denmark, in Germany, in Belgium, in Australia. No, I don't anymore. In Cape Town, in Pietermaritzburg, in Port Elizabeth, it was always full. Now it's full only here because I'm not going to go everywhere anymore. But it works. It's true. It's not a dream. It's not a wind. It's a reality. That Tunisia still has those tales since 1936. It's not a dream. I'll show you the photos. And why Tunisia only? Not in Paris, not in New York. I don't understand. No, it's a big mystery that such a big entity is missed by the classical medicine. That's a nonsense.
I think of the three monkeys: see no evil, hear no evil, speak no evil. Except the first thing is test nothing, and you won't hear, you won't see anything, and you won't report anything.
Yeah.
Nick
Why?
and Mr. Paradise, do you have any questions? I review.
Mr.
Remember to
Paradise.
unmute yourself first.
Mr. Paradise.
Hi everyone.
Nickname.
You can go first if you want, Mr. Paradise.
Oh no, I'm fine. I'm good so far. I have no questions, but thanks for asking.
Oh, sweet.
Nickname.
Right. Yeah. Hi everyone. So I wanted to talk about a couple of different things. Firstly, the ciprofloxacin.
Yes.
How many patients have you used that in before, and how many have had a negative response?
Probably since it was born, meaning 40 years ago, and I write it probably 10 to 20 times a day. And I had not one complication.
Okay. There's cases in the literature. There's a couple of people that I speak to who have a fluoroquinolone associated disability, and it's something that's thought to be of a similar etiology to chronic fatigue syndrome, and that there might be some form of mitochondrial dysfunction.
I haven't come across that.
Okay,
You
no,
know,
that's really good to hear. Yeah, that's good.
Yeah, there was a woman that wrote a book about ciprofloxacin. She swallowed one tablet and she was paralyzed for the rest of her life. So she wrote a book and she wanted to sell that book, and she did so much publicity in all TV programs everywhere in the world. And I think it comes from there. Because I've got often patients that come and they say, we don't want ciprofloxacin because of that. And I say, fine, we're going to take the other regime first and you will see. And then they beg to have ciprofloxacin. And they do take it and nothing happened.
There is a chance that the problem could arise from additives added to the capsules. That it's a particular combination of additives, which may not be in the South African version, but are in the American version is where the problem is. It's the addition of additives is always problematic.
That's possible. That's very possible. But I've got American patient. But in America, it's not easy to have antibiotic. In Canada, it's almost impossible. In France, no, impossible. You have to be hospitalized to get some antibiotic. So that there's so many laws now that makes the doctors put the doctors in a cage. They're already quite disturbed, I think, in general. But now with those laws on the top, where do we go?
And in the U.S., there's litigation risk constantly, which is probably really keeps doctors to only what is officially approved.
I know. And no, it's a world problem.
How about you, Tess? Any questions? Or are you pretty good this time?
Yeah, no, I'm good. I think I learned a lot last time, and then we chatted afterwards. I'm good.
How about you, Catherine? I haven't heard much from you. Any questions? Unmute yourself first.
There we go. Thank you so much to Dr. Jadin for such an interesting talk. I'm in fact a patient of Dr. Jadin's. I'm also a clinical psychologist that really became unable to work and had been to multiple specialists over 10 years. And I began her protocol just 3 months ago, and it's been transformative. So I'm starting to get a little bit of brain function back, a little bit of capacity back. I'm still low and slow at the moment, but I really wanted to just learn more. And I'm very, very, very grateful for the beginnings of the light at the end of the tunnel. So just to reflect that I'm on the protocol, and even within these few months, it's been very transformative. Yeah, thank you.
Relating your brain fog, your stupor. Stupor is gone.
Not entirely, comes and goes, but there's some clearing, you know.
That's the first thing that works.
It's amazing. It's amazing to experience.
I'm not sure if it's available easily. Is what I found helped greatly with my stupor is something called parasitium. Parasitium,
yes.
right. And it basically
also,
helps with oxygen delivery to the brain.
Definitely. It's not available here, but in 2 weeks' time, I go to Europe and I'm going to buy 40 boxes. It's called Nootropil, the other name, Nootropil. Yeah, and it's really working well. Piracetam.
Excuse me, Ken, could you spell it again?
Piracetam.
Piracetam, yeah.
C-E-T-I-A-M.
Yeah, that's it. That's
800 milligram normally, but for big people, 1,400 milligram.
Yeah. And basically, I should warn you, it has one known side effect. For females, it will get them amorous.
Well, that's not a bad side effect.
I never said it was a bad side effect. I said it had a side effect.
By the way, I also would like to point out that I wrote books that are available on Amazon, Kindle, a disease called fatigue, and another book, The Crazy Journey of a Medical Chameleon. It's very informative and speaks about patients, about my experience and all that.
Sounds awesome. And so, if no more questions, then I probably would not mind getting up to bed. And Cecile, if you want to do another one of these, just shout and I'll try setting it up for you.
Yes, I've got many. I'll show you here. If I go there, no. Here, you might see it. or you might not.
Yes.
But every little dot is a conference that have been given in America or in France, and I can do them again. They're all different subjects.
Excellent. Then
So
we'll
there's like
talk
200.
offline,
Yeah,
and we'll see about trying to perhaps to do one a month or one every 2 weeks, and just build up the material.
with pleasure. One a
Okay.
month would be good.
Okay, that sounds good. And I will send everybody links to the video online. And hopefully one of them will be with subtitles, and I'm not sure, that one may not be the highest quality, and then there'll be one which will be much higher quality, but without subtitles. So, but both should be quite readable. So if there's nothing more, then shall we say good night or good morning or whatever?
Thank you.
Thank you.
Thank you.
Thank you. Thank you. Wonderful.
Thank you. Bye. See you soon, maybe.
Bye-bye.
Bye.
Bye.
Thank you, guys. See you.
Thank you, Ken.
Thank you. Thank you.
Bye-bye.
Bye. Bye.